Here's lesson 15 in the EMT course. We're going to talk about patients who fall. Very common call that we run. This is about an hour online, then a couple hours in lab. A lot of this stuff we've already done in terms of injury management. But again, because falls are such a common call for us, that we thought a lesson and some scenarios were very appropriate for this particular topic. The big thing is the cause of the fall may be a bigger deal than the injuries from the fall, and so we want to be aware of both of those issues while we manage them in priority order. Again, I kind of let it out of the bag already. The big idea is that patients fall due to many, many causes. Sometimes they just trip. Sometimes they have a significant medical event that causes the fall, and that might end up being a bigger deal. The patient who's on the ground with a hip fracture has a significant fracture, but if that person had a cardiac rhythm problem or syncope from another reason, that may be more life-threatening. They would end up healing. The hip will heal, but what caused that fall probably hasn't been dealt with. So take care of the basics, treat the injuries, and then consider the cause of the fall. So what are some potential causes? Well, people that are unsteady on their feet, that slip or trip, is probably the most common thing. But that could also be a syncopal episode. They could have fainted or had near syncope, were weak, dizzy. Maybe they had a cardiac rhythm problem. Maybe they had a neuro problem. And, we had a lesson on weak and dizzy and syncope. And this is another place where it comes in when that patient that became weak, dizzy, or had a syncopal episode ended up having a fall. And now we need to manage some injuries as well as investigate the cause. Wound care is pretty simple. We've been over that in the trauma lessons and have practiced that. Stop the bleeding, keep it as clean as possible, put a dressing on, secure that with a bandage. A lot of older folks will have skin tears when they fall, and those are just kind of a pain to deal with, a pain for the patient, a pain for us. Cover that up as best you can, and just be aware of hidden bleeding sources. Musculoskeletal care, again, we've done this in the trauma lessons, but we want to integrate that now and revisit that stuff. You want to stabilize injured bones to limit pain and limit the internal bleeding. Splinting doesn't just help with pain, it helps with internal bleeding control, and there really isn't much else we can do about internal bleeding control, so splinting makes a great deal of sense. And then consider if they have lost volume. Either they've been they've injured areas that bleed significantly, or they've been down a while before they were found or before you were able to start care for them, and they've been bleeding for a while. Remember, with splinting, usually the general rule is if it's above the waist, it needs a rigid splint and a sling and swath. If it's below the waist, it needs a rigid splint and a scoop or a backboard. Those are general rules. Certainly the guy with just the wrist pain probably doesn't need a sling and swath. A rigid splint will be enough. A guy with toe pain doesn't need to be on a backboard. But in general, if it's a tib fib, it needs a rigid splint, and then probably the best way to carry them or move them is a scoop or a spine board. It might be a soft stretcher. If that person has anything elbow or humerus or shoulder, clavicle, anything like that, sling and swath is what you need. The rigid splint is good, and you should use it, but the sling and swath is what they really need. So just a review of general splinting. And so while in the trauma lessons we kind of had an isolated lab where we said the ankle hurts, fix the ankle, now we're going to have a patient with a full scenario who has fallen, and fixing the ankle is part of your management, but not the entirety of it. We run a lot of falls with hip pain, and so these are hard. There's no perfect splint for these. These patients hurt. We're hoping that the patient is stable enough and the ALS care is appropriate, and we can get some pain control for these folks before we move them. Sometimes that's not possible, or sometimes it's not even reasonable, but in many cases it is. So these calls will tend to be a little bit longer scene time than you may be comfortable with. And you're kind of incentivized to think of trauma and go fast. But in cases of pain control, it takes a little bit of time to get vascular access. It takes a little bit of time for the meds to work in. Even if we don't use an IV, it takes a little while for pain meds to work in IM or intranasal. And so pain control, nausea control prior to moving is the best bet when it's appropriate. And we'll let the ALS providers make that judgment, and we'll assist them. As far as how do you move a patient with a hip fracture, well, again, nothing's good. Scoop stretchers work in some cases. In other cases, it seems like there's more movement there than if we just pick them up with a direct lift. Sometimes you can get a sheet under them. Sometimes you can use clothing. Sometimes a spine board slid onto the spine board, probably not log rolled, but slid onto the spine board may make some sense. It's judgment calls, which you make better judgment calls after you've had some experience. So we're going to try to provide you some pseudo experience in the lab setting and have you work through these problems and try to do the best you can. These patients are going to hurt. They hurt unless they move, and there's no way to not move them as we transfer them to the cart. And I think we made a big enough deal in the trauma lessons about how traction splints don't work for hip fractures, but I wanted to say it again. The pelvis must be intact, and unless you have x-ray eyes, there's no way you can know that the pelvis is intact. So a traction splint on a hip fracture is just plain bad medicine. So leave those alone. So hypovolemia, what fractures can cause significant blood loss? Well, any fracture for a long enough time with no control can cause considerable and significant blood loss. But for the most part, a pelvis, femurs, large, long bones can cause significant blood loss. Many cases, we are able to encounter and care for the patient shortly after the fall. And it's not a big deal, but always consider the possibility that they've had a long downtime. And if they've had 2 or 3 hours or more since the fall, since the injury, then the blood loss can be legit. Now, what can you at the BLS level do to deal with hypovolemia? Well, you don't have any options to replace that volume. Blood loss would be best replaced with actual blood, and very few, if any, ALS services even have that as an option, so they're stuck with a really poor second choice in IV fluids. But at the EMT level, we can't even do that. So what do you do? Well, I think detecting the hypovolemia is the first priority, and then keep them warm, lay them down, oxygen, that sort of thing, the usual management of shock. But consider that these folks may be taking medications, maybe something that kind of governs their heart rate, keeps their heart rate from increasing to compensate for the low blood pressure. Maybe they take medicines that prevent clots, because on a daily basis, they need prevention for heart attack and stroke, which are caused by clots. So they take medicines that are clot preventers, blood thinners, aspirin, and Coumadin, and other things like that. So those medications work for them on a regular basis, but they almost work against them, and do work against them in some cases during a trauma. So it would be important to identify what medicines the patient's on, or at least, if they don't know the name, what are they for? So beta blockers that end in LOL, the medication name ends in LOL, the generic name ends in LOL, those kind of govern the engine. Those keep the patient's heart rate from increasing, as would be helpful in hypovolemia. So look for those meds, and then consider all the injuries, not just the one that the patient called you for, is complaining of. And you walk up to the patient, you say, "What's going on?" They say, "Oh, my hip hurts." Let's make sure we also find any upper extremity injuries, a humeral injury or something like that. And then another little word about shock versus hypotensive blood pressure. So if we told you that a patient had a blood pressure of 110/70 Could you say if they're in shock or not? Well, no. If I told you the patient had a blood pressure of 70 over 20, you'd be able to say they're hypotensive and clearly in shock. But shock is really assessed by other than the blood pressure. And so a patient can be shocky and have a normal blood pressure is what is the takeaway here. And again, blood loss is best replaced with blood, which is done at the hospital. And so that's how we deal with hypovolemia. Spinal motion restriction, we talked about that during the trauma unit and some of the trauma lessons. And I'm not slamming on the National Registry. I'm just saying that the National Registry continues to insist that we do spinal motion restriction and spends a bunch of time testing that, whereas local protocols have modified their spinal motion restriction to exclude a backboard in many cases. The backboard is useful for moving the patient to the ambulance cot, but then once they're there, the backboard is removed. And so you've still got this kind of conflict between what registry wants you to do for the test versus what you do in the real world. And I'm sorry about that. I really dislike these sorts of things, but we don't have a way to work around it right now. Another thing, remember, is that distracting injuries and altered level of consciousness or altered mental status may make it impossible for you to do a valid exam of their spine. And so regardless of anybody's protocols or whatever, if a patient has tenderness to their spine, spinal motion restriction is appropriate. And if they have a very, very painful other injury, or they're a little bit altered, or their level of consciousness is decreased, then you may not be able to get a valid exam, and your best bet is to do spinal motion restriction just in case. The caveat here is that what's wrong with backboards is that when patients lay on them for a long time, they develop back pain from the backboard for a long time. Not for a few minutes, but for a long time. And so let's don't completely disregard the use of backboards when they make sense and they're good for the patient because of some attitude or local fad where we've said, well, backboards are bad. No, backboards are not always good, but backboards can be useful, and particularly in patients that have fallen. So find the cause, find the cause, find the cause, deal with the injuries, but then let's also consider, why did this happen? And it may be that they just slipped and tripped. Or it may be that they had a seizure, their glucose is low, they're drunk or stoned, maybe they had something neuro going on, maybe they had some vertigo. Think back to the weak and dizzy syncope lesson and bring all that stuff to bear here. And then the number one thing I listed there was a cardiac rhythm problem. And so it is possible that a person had a cardiac rhythm disturbance, like an episode of VFib or VTAC. In other words, they were in cardiac arrest briefly, and that caused them to fall, and then that resolved. That whatever caused that to happen didn't get fixed by the fall. It's still there. So that's some of the stuff that we're working on and trying to deal with here. Another thing you should think about is fall prevention. Now, in the fire service, we pretty well put ourselves out of the fire suppression business. Hardly anything burns anymore because fire prevention has worked so well. Maybe we could work that toward fall prevention as well. So if you're at someone's house and you're not immediately needed to engage in patient care, maybe a quick survey and an attempt to prevent the next fall would be appropriate. Maybe you do that on almost any call. You don't have to be called for a fall. Maybe you're there for shortness of breath. Maybe you're there for abdominal pain. Maybe you're there for something very, very minor. Then, a quick survey with their permission. I'm not saying we go snooping around people's houses, but you would be amazed at the number of trip hazards and other things that you can find. And maybe we could prevent that fall. Because really, as you may know, some elderly folks, it seems like they maintain okay on their own. And then, they're able to live on their own independently. And then they have a fall. And they just never quite get back to normal. And they don't die from the fall, but it's the start of a series of events that ends up in their demise. So let's try to do fall prevention if at all possible. So summary slide here about just running this call. Continuous safety assessment, situational awareness, as with all calls, some more than others. This is a little old lady who fell in her house. You know, if the scene's safe enough to enter, it's not like the scene changes dramatically there, unlike a motor vehicle crash that's very dynamic. But an ongoing safety assessment, the walk in the room, scene safe BSI does not work for us. So a continuous assessment, do your CVO, start that urgent care, find any bleeds, limit the patient moving around, find all those injuries and start dealing with splinting and stabilizing, and consider hypovolemia, consider their downtime, and then consider the cause. So that's pretty much what we need to talk about with patients who fall, and we will work some calls in lab, and we'll see you there.